So basically, I'm going to talk about the spinal engine and the fact that when we're walking, the iliums should basically be moving around the sacrum. I'm going to talk about an iliosacral upslip, which can be real nasty to try to walk when the ilium slips up around the sacrum. If you had pelvic abdominal scars, I would not do therapy until I treated the pelvic abdominal scars, C-section herniations with microcurrent and vagal nerve stimulation. So that would be my starting point. So I'm going to start by assessing capsular patterns. You can see her feet are turned out. So it's obvious she probably has tight lateral hip rotators. She probably maybe lateral tibial torsion. So it's a checklist. It's not a treatment protocol. The first thing I check is, can the femur internally rotate independent of the ilium? And the answer is no. It can laterally rotate, and that's a soft infill, but internal rotation is a hard or bone-on-bone like infill. So stretching is the thing that's going to make this go bad really fast. Stretching is just going to really cause problems with her back. So the first thing I'm going to do is she's sort of guarded. So I'm going to just take the leg and rock it a little bit. Just a little trigger, a little distraction. Then what I'm going to do is step forward just to relax the capsule, which holds the femoral head inside. And then as I do a little distraction again, I'm going to stretch the capsule just to pull in synovial fluid and hyaluronic acid. And I'm trying to get the femur to move independent of the ilium. And usually if you do that 1 or 2 times, relax the capsule, distract, stretch the capsule, pulling in hyaluronic acid, synovial fluid, you'll see that now the femur can move independent of the ilium in both degrees of rotation. But I want it to be brain-related therapy. So I'll hold the ilium and I'll hold the femur. And can you feel the femur moving into either we need a yaw? So the femur, a nod or a yes makes it brain retention therapy. Everything is about changing the brain. So I don't do more than 1 technique. I check in. I don't do 3, 4 techniques and then check in. I check in on every technique. So the next assessment is I want to make sure the femur can laterally rotate. This one has a bilateral restriction, and this is a hard infill. So now I'm basically going to step in, get her to relax through distraction. I'm going to relax the capsule, stretch the capsule to pull in synovial fluid and hyaluronic acid and start to recheck the rotation of the femur. And basically now the femur can rotate lateral and medial. And then I'm going to check in, can you feel your femur moving independent of your ilium? And that yes or that nod makes it brain-related therapy. Then basically I'm going to check, we've got 1 sacrum and 2 iliums. And when you're walking, we should have about 5 millimeters of movement of iliosacral motion. That's what gets nutrients to the ligaments. If you have an iliosacral upslip or an iliosacral torsion, and you don't treat that, you can't do soft tissue care really. So what I'm going to be doing is I'm going to be finding the ASIS in its relationship to the PSIS. I'm going to be outflaring the iliums in the front to relax the ligaments in the back. It's called positional release of the articular ligaments. So basically I see that she's extremely anterior on the right. So right anterior rotated ilium. So basically that would mean that we're going to correct this pattern. And I educate the patient on the corrections. First thing I'm going to do is I'm going to unlock the pubic symphysis, knees together, feet together, and then we're just going to have you slowly squeeze your knees together, which fatigues your adductors. Do a little bridge for me, and I just oscillate. That unlocks the pubic symphysis. Then pull your knees apart, then come up into a bridge, and I'm going to oscillate. Does the bridge cause discomfort? If the bridge causes discomfort, I only do this once, but if it did, I would just say, don't do a bridge, just flatten your back. Once you fire the glutes, I can unlock the pubic symphysis and knees apart, and I can unlock that. If you had pelvic abdominal surgeries, I would now do microcurrent to the scars. The next thing we're going to do is we're going to outflare the iliums with breath work, deep breath. And I'm going to just come up a little bit with this table. Here we go. Might as well use the magic of the Cardone table. Take a deep breath. That way I have better body mechanics, and I just oscillate. I'm trying to relax the iliosacral ligaments. What's referring into your back when you have a torsion is not trigger points, it's articular ligament, it's referral pain patterns based on the studies of Robert Libby. Now use your muscles to engage the motion. Is that uncomfortable? So we're going to recheck and probably overactive QLs, but your iliums are even in the front, so they got to be even in the back. Then we're going to slowly go prone, face down for me. And basically, one of the things that makes things go really wrong really fast is when you try to lift the leg, if the ilium moves with the femur, you're jamming L5S1 and you're causing an iliosacral torsion. So I'm going to come up just a little bit more with the table to do some capsule work. So basically this technique hydrates the anterior capsule and increases synovial fluid. It actually stretches the iliofemoral ligament, stretches the rectus spem, and it frees the femur up from the ilium. So gently push this right knee into the table, 5, gently 10% of that, 4, 3, 2, 1, relax. I'm going to decompress L5S1, stabilize the sacrum, stabilize the ilium, lift your leg up. I'm going to stretch for 2 seconds. The femur is the only bone that moves when you do it that way. And I'm going to do that on both sides, and then I have 2 techniques left. Basically, you can see if I lift that leg, that ilium's going forward, and you're going to cause that problem to come back. So you don't want to go into an iliopsoas stretch until you actually hydrate the anterior capsule, a technique that also stretches the iliofemoral ligament and rectus spem. Gently push your knee into the table, 4, 5, 4, 3, 2, 1. Decompress L5S1, lift your leg up, 2 second stretch. Probably 80% of the clients I see, because we sit a lot, have weak glutes. Weak glutes mean overactive QL. So I'm going to check muscle firing patterns. What should fire first is gluteus maximus, then upper hamstrings, opposite QL, same side. Go ahead and raise this leg up, way overactive QL, so glutes have to be activated. This is like, you're going to find this checklist on everybody. Go ahead and raise this leg up, really overactive QL. So what's raising her leg is hamstrings and QLs. Every time she goes to pick something up, overactive QLs. No matter how much you do to treat the lower back, you're wasting your time if you don't activate the glutes. So let's slide to the left side of the table. I like her to stay on the table, but I like her knee to come off the table, because in order to do spindle cell work, you have to put gluteus maximus on a mild stretch, and then you have to do fast-paced spindle cell work. This usually takes a minimum of 30 seconds and probably up to 2 minutes. And if I have to do 2 minutes, I'm probably going to use the mild body to do this, because I'm officially a senior citizen now, and I don't want to work as hard as I did before I turned 66, 67, or 68. I don't want to work that hard anymore. Work smart, not hard. Now, if I check muscle firing patterns, go ahead and raise this leg. Glutes are functional. Let's do the other side. Come on to this side. Thank you very much. So basically, you put it on a stretch. If you don't put on a stretch, you can't do spindle cell work. So you got to do approximation of the muscle with some spindle cell firing. And just a checklist. We're going to make sure we wake this side up. And then we're going to come back to neutral. I'm going to check that out. Go ahead and extend there. They're both working. And now I'm just going to treat iliolumbar ligaments. Most people have compression at L5S1, bulging disc, herniated disc, ruptured disc. You're trying to drop the sacrum back. You're trying to get the iliolumbar ligaments working. You're trying to get the iliosacral ligaments. The only thing that really gets nutrients to ligaments is joint play. And I'm just creating some joint play in here. Good functional movement of the sacrum now with even PSIS, even SI, ischial tuberosities. Last technique, we'll scoot back to the middle of the table. Thank you very much. Is I was going to stretch the piriformis, but I can't. It's a hard infill. Again, stretching is contraindicated. When I was younger, I used to say I wouldn't recommend it, but when you have a hard infill, stretching is going to mess with the low back. She's really good on lateral rotation, but she's very restricted. Infill means, what's it feel like when it stops? If it's hard, it's usually either a hip replacement, scar tissue, secondary muscle guarding, or lack of synovial fluid and hyaluronic acid. So I relax the capsule, stretch the capsule, pulling in synovial fluid. When I stretch, I only use 2 fingers or approximately 5 ounces of pressure. If you have fluid going into the hip, you can actually stretch with 2 fingers. So now I have a balance between the hip rotators for more centralization of the femoral head. 1 technique left. This one checks out okay, so I leave it alone. I don't treat stuff that you don't have. This one has a good balance between internal and external hip rotators. I can check the lumbar. Let's just teach you some slow pelvic tilts, and you're going to keep doing that. And when you do that, as you tuck your sacrum, I'm going to decompress, try to get some, and now I would do some really good soft tissue care if needed. And then we're going to bring people up through the other stuff. So that's my first part of the demonstration. Thank you very much.